about diabetes, and then we start off. So for the team online, you can give us some of the expectations that you're expecting in this for this session. Yeah, any volunteers?
Good afternoon.
Yes, go ahead.
Yeah, my name is Thomas. I'm from Kenya. I'm a clinic officer with my specialty is emergency and critical care. Looking forward to these wonderful insights about diabetes management and their complications. My question was now in terms of specifically ICU management, specifically now DKA. Now that this conundrum in terms of fluid of choice, the isotonic fluid of choice to use, normal saline and whatever the Ringer's lactate or rather Hartmann solution. Now this conundrum, because most of the DKA patients, most of them they are dehydrated, that this conundrum of using normal saline, then on the flip side, you have this association of normal saline with the hyperchloremic metabolic acidosis, worsening rather the metabolic acidosis, which is common, the high anion gap now in the DKA. Then on the flip side, there's some who recommend Ringer's lactate, but on the flip side again, there's some patients in DKA you get them probably you have sepsis. So normally when you do a BJ, they tend to have elevated lactates. There's another again this issue of if you give lactate, it tends to elevate lactates. This is the clarity I wanted. Thank you.
Yeah, thank you very much. And the team will have taken note. Yeah, any other questions or expectations?
Yes, good afternoon.
Go ahead, good afternoon.
This is Benjamin, a clinic officer from Masaka, Mokwaya Medical Center. My expectation from this talk is mainly about how we can manage a patient who has both, who has an emergency, for example, MakCHS or diabetic ketoacidosis, together with the hypertensive crisis, for example, hypertensive emergency, because the kind of treatment because in the diabetic ketoacidosis, the main therapy would be rehydration. And now if someone is having if someone is having hypertensive emergency, I would feel rehydration would not be a good choice for this patient. So I'm just asking for clarity on how we can go about with this.
Yes, thank you, Benjamin. I think that will be looked into. The team is here. Another final one last expectation or question, and we'll go to the pre-test.
Yes, good afternoon.
Yes.
My expectation is me, I'm a medical officer, Lila University Hospital.
Yes. Hello. I think we have lost him. Another person who can.
I think it unmuted. My point was about DKA in children. Don't forget, please, to put more light on it.
Okay, we have noted the point DKA in children. I see people answering the pre-test, but we are still few. Maybe we can have another question from the team or another expectation as more people are responding to the pre-test. So,
good afternoon, colleagues. Let me take it up from here. I'm Felix from Kiriandongo. I hope I'm audible enough, right? Am I clear?
Felix, you're very clear.
All right, thank you. I would like to understand the relationship between DTG, that is the drug used for HIV treatment, with treatment for diabetes, because somehow there seems to be some contraindication when someone has uncontrolled sugars. So you'll highlight on that, how there is a relationship between DTG and the people with uncontrolled sugars. Thank you.
Yeah, thank you. Thank you, Felix. I think we can go straight to the poll, and I see the first question we are looking at what constitutes diabetic emergencies, and the answers are there. We have seen, you have given your responses. I think when we go through the presentations, we shall be able to see how the answers will be at the end. So I think we can go ahead and start. And our first session is about a case presentation by Dr. Ambrose. Yeah, you can go ahead and share with us the case. Yes, good afternoon once again. I'm presenting a case of NV, a 60-year-old female who had no known chronic illness, brought in at emergency in Kiruddu from home with a history of loss of weight that had been on for the last 4 months, irrespective of the increased feeding. It was not gaining more weight, it was just losing. Then a day prior to admission, became more drowsy. And this was actually to fevers, loss of consciousness 3 hours before admission, had abnormal forced breathing, productive cough, and 4 episodes of convulsions. This was corroborated from the granddaughter. But these convulsions were not observed while in the hospital. Next. So we did a primary survey. We assessed the airway. It was patent, but it was threatened given that the patient had reduced level of consciousness, and we aimed at maintaining the hair patent. Then we assessed the breathing, and we found that the patient had severe respiratory distress with small breathing. The respiratory rate was increased to 32 breaths per minute. It was saturating between 79 to 84 at room air. The air entry was equal bilateral, but with coarse bilateral crackles. So we had to put the patient on oxygen, 12 liters per minute by non-rebreather mask, and this increased the breathing. This increased the saturation to 98% on oxygen. Then we assessed the saturation. The capillary fill time was more than 2 seconds. He had cold extremities, had increased pulse rate, and the pulse was thin volume, but it was regular. The blood pressure was low, 79/53 millimeters of mercury. The heart sounds were normal. So we had to initiate 2 large bowel cannulas, and a sample was taken off for the investigations. And within the first 1 hour, we were able to infuse 2 liters of normal saline, giving the first 500 mils within the first 15 minutes. And at 45 minutes, the blood pressure had increased to 112/82, and the pulse rate had reduced to 102 breaths per minute. Then we assessed the disability. The patient was semi-conscious. The GSS was 9/15, and this was markedly reduced with the eye opening, which was 2, and verbal, which was 2. The pupils were of normal size, about 3 millimeters, and were equal and reactive to light. The neck was soft, scanning was negative. The random blood sugar, which was taken off at that point, it was L8, meaning that it exceeds what the glucometer would record, meaning it was above 33.3 millimoles per liter. So the patient was put in the recovery position, and we were able to pass a urinary catheter, and the sample was collected for analysis. 2.5 units of atropine was put in each 500 mils of normal saline, and we aimed at pushing this within 1 hour on both sides. Such by the end of 1 hour, we were able to infuse 5 international units of atropine, and this was repeated for the next 2 hours. So at 2 hours, we were able to give our subcutaneous lantus insulin, which is insulin glargine, 12 international units start. And as we are waiting for the results, we anticipated the possibility of going into hypokalemia. So we had to give a dose of 40 millimoles of potassium chloride that was infused. Then we went ahead to expose, and we checked the temperature. It was normal, 36.2 degrees Celsius. And we didn't see any life-threatening injuries. We covered the patient to keep warm, and we continued the fluids. In our secondary survey, in the general exam, the patient was very sick looking, wasted, in severe distress, was semi-conscious, had severe dehydration, had no pallor, no jaundice, no cyanosis, had no edema, and had no lipidinopathy. The cardiovascular at that point, the pericardium was non-active, had no obvious mitral or parasternal hits. The heart sounds 1 and 2 were heard with no any added sounds. In the respiratory system, the chest shape was normal, and the trachea was central. It had normal resonant percussion note, and air entry was equal bilaterally. However, there were post-fractals that were had bilaterally. The abdomen was scapate. It was moving with respiration. He had no tenderness, and no abdominal organs or muscles were palpable. ENT had good oral hygiene, no nose or ear discharges or any tenderness. And the CNS, what was markedly, it was the reduced level of consciousness. The GSS was 9 out of 15. Significant, the verbal was 2, the eye was 2, and the motor was 5. The pupils were equal and reactive to light. The tone was normal, but reflexes were reduced. All reflexes that we examined were reduced. Then the muscles, musculator, she was wasted with reduced muscle bulk. So signs and symptoms, it was mainly the obvious weight loss, which the granddaughter reported, the loss of consciousness, which had excess 3 hours prior to admission, the 4 episodes of general chronic conversion that we didn't observe within the hospital but occurred at home. Then also she had developed dizziness a day prior to admission, and she was eating, but she never gained weight, and she also had cough. Then the sign is that we were able to see she had forced breathing. She was semi-conscious, confused, with prominent zygomatic arches and sunken eyes, with dry mucous membranes. Significant, the lips were very dry. She had no history of allergies to any food or drugs, and medication, she was not on any chronic medication, and never had she taken any drugs prior to admission. So in the past medical history, this was the first admission that she would, of recent, and she had no history of any chronic medical illnesses. In the past surgical, she had no history of any operation, blood transfusion, or any trauma. And family social, she was married to one man with 6 children and one daughter, the eldest daughter of hers, had both diabetic and hypertension. She had no history of alcohol, smoking, or any other drugs. And last meal, she had taken a meal in the morning of that day, 8 hours prior to admission. And also last menstrual period, she was in postmenopausal. So the events, the patient was found with reduced level of consciousness in her bedroom, 3 hours prior to admission, unknown time of onset, and this was the first episode in her life. So our problem list, it was unrecordable hyperglycemia, which can be DKA, it can be HHS, loss of consciousness. She had convulsions, hypovolemic shock, severe dehydration, abnormal forced breathing, and cough. So we did some investigations, and these are some of the investigations that we did. Significantly, the random blood sugar was elevated beyond the recordable level of our machine, and probably it was much higher than 33.3 millimoles per liter. We did the RDT very fast, which was negative, the CBC, which had a slight elevation in white blood cells, and predominantly it was neutrophils, and other parameters were normal. The urinalysis that was done, she had ketonuria of +3, glucosuria of +3, and the urine pH was 6.9. The nitrates were positive. Other parameters were normal. Then the pus cells were +2, epithelial cells +1. There were no hematuria, there were no blood. Then in the serum electrolyte, significantly, there was hypokalemia of 2.9 millimoles per liter. The bicarb also had reduced 14.2. Sodium and chloride were normal, but when we calculated the anion gap, we got 30.7, it was elevated. The renal function test, significantly, the creatinine was 9.8, which was in the normal range, but could be higher for somebody who was wasted. Then the renal function test, the liver function tests were normal. HIV test done was negative. The chest X-ray, which was done, showed heterogeneous opacities bilaterally, but there were no hilar lipidinopathies and were no any features of effusion. The sputum expert that was done when she was able to give us the sample, it was negative for TB. HbA1c was elevated to 11.2. We were unable to do arterial blood gases and ECG, which was also important in this patient. Unfortunately, it was not done. So our diagnosis at this point, it was newly diagnosed diabetes mellitus complicated with DKA, with the possibility of overlapping with the hyperglycemic hyperosmolar state, and also severe hyperglycemia. Because of the findings, the reason for us to diagnose DKA in this patient, because this patient has very elevated unrecorded blood sugars, and also had a lot of ketones in the urine, and also had increased anion gap with very low bicarbonate ions. And for hyperglycemic hyperosmolar state, we think that since the blood sugar levels were very high and recordable, it is possible also to make a diagnosis of hyperglycemic hyperosmolar state in this patient. Then bronchopneumonia, it is a stronger possibility, which could also be a trigger for our DKA in this patient who was unknown to be diabetic, who had undiagnosed diabetic for some time, most likely, because of the difficulty in breathing, the cough that was productive, but also significantly, he had heterogeneous opacities on the chest X-ray. So this could have been a trigger for DKA in undiagnosed diabetes. Then this patient also, we think about UTI because of the urinalysis finding. There were past cells, but significantly the nitrates were positive in her urine. But even in elderly, confusion and loss of consciousness can be one of the signs UTI can present with. But this was further supported by the urinalysis findings, but also it is possible that UTI might have been a trigger for DKA in undiagnosed DM patient. Then the differentials we thought about was pulmonary TB, which was ruled out by doing a gene expert on the sputum, and also we did RDT to rule out malaria, which could even cause cerebral malaria, which can go to the brain to give us cerebral malaria that could cause convulsions. So another thing that was complicated this DKA could have been electrolyte imbalances. Given the hypokalemia we had, it was a complication which can come as a result of the disease or management. Then in the management of this patient supportive, we were able to improve the oxygenation by giving 12 liters of oxygen per minute by non-rebreather mask, and we kept our patient warm by covering her with blankets. But also we were able to push the patient out of shock. She had a hypovolemic shock. We were able to push her out of shock by giving the normal saline. It was our resuscitation fluid throughout her stay in the hospital. And within 15 minutes, we were able to give 500 mils because our systolic blood pressure was less than 90 millimeters of mercury. Then we gave the next 500 mils in the next 45 minutes. And when our systolic blood pressure had gone high, we were able to continue with 1 liter in another 1 hour. We immediately, after resuscitating our patients and the blood pressure had pulled up, that is when we started the IV Atrapid, about 5 units per hour infusion, and also 1 liter of normal saline had to continue because our patient actually had 2 lines. And this was repeated for the next 4 hours. The subcutaneous Lantus insulin glargine 12 international units was started at 2 hours later. We started our basal insulin much earlier because we were worried of the possibility of our patient undergoing episodes of hyperglycemia. So we didn't wait for the last 4 or 2 hours to start our basal. We started it early because of the experience we had previous in managing this patient, and they kept on going into hyper. So then we monitored our random blood sugar hourly and the urine ketones every 4 hours. After 6 liters of normal saline, random blood sugar was 13.2. We gave the 500 mils of D10. Then we continued the Atrapid now at a half dose. Instead of giving 5 international units per hour, we reduced this to 2.5 international units per hour with normal saline, and we continue to monitor the random blood sugar, we continue to monitor the urine ketones, and after 24 hours, our patient had stabilized, the ketones, the urine had cleared, our random blood sugar was 9.8, and we were able to stop our infusion and started on the basal bolus, as you see. So this patient was then fixed on basal bolus, Lantus, 12 international units, and Atrapid 4 international units per mil. Our patient was around 48 kilograms. So when we fixed on that dose, our sugars got actually more better. We corrected for hypokalemia. We started with the 40 millimoles of potassium chloride, which was given initially at the starting of the treatment before the investigations came out. Then we continued with 20 ml equivalent for every 1.5 liters of normal saline that we gave on the first day. Then, because of the potassium level that we had measured on daily basis, we had to continue for the next 2 days with 20 ml equivalent twice daily. Then we continued monitoring these electrolytes. We were unable to monitor daily given our resource set hourly, given our limited resource setting, but at least we are able to get daily readings. Then we gave ceftriaxone 2 grams only for 5 days to cater for the UTI and also pneumonia. Then the chest infection, after consultation with pulmonologists, they advised us to add azithro, which was taken for 5 days. Next. So in follow-up, our patient actually greatly improved. The level of consciousness improved back to 15, 12, then final to 15. The breathing improved. And we continue to monitor the random blood sugar, the urine ketones, which finally cleared. And our potassium levels, we were able to raise it to 4.5. And the urinary catheter was removed on day 2. She was fully conscious by day 2. The caretakers were educated early, and when the patient was fully conscious, we were able to explain the lifestyle, the diet, the injection technique, the insulin storage. So we offered health education to the caretaker, to the caretakers, and also to the patient. And we monitored their vitals, and we are stable. By day 4, our patient was actually walking and very okay. So, and finally, after fixing our patient, we discharged on basal bolus 12, which we are taking at night, and that rapid, pre-lunch, pre-breakfast, pre-supper. And on day 4, our patient was discharged with our random blood sugar that we had monitored that was ranging between 7.6 and 11.5 millimoles per liter. And the patient was advised to return in the diabetic clinic for review after 1 week. Thank you.
Yes, thank you, Dr. Ambrose. Yeah, we have like one question in chat.
Yeah, we have some questions in the chat. And yeah, I think we can keep the questions for the next session, and we go through them at once since we are running late with time. Yeah, let's introduce Dr. Martin to give us the overview and assessment.
Thank you very much, Dr. Twinamatsiko. Is my presentation there? Thank you. And I want to appreciate the previous speaker. I think the subject is very well handled. I don't know what else we need to add, because that's a classical case. Of course, there was a controversy. Is this HHS? Is it DKA? That was a little bit of a controversy, but it was very well handled, and the patient left hospital. So we should not despair. These people can be saved if you work hard, like they worked hard to get that lady. And then there is always the question: DKA presenting late in life for the first time? It can, like that case was. She was postmenopausal. I didn't get her age. 60, presenting with diabetes for the first time and in DKA. I was given the task of going through overview, assessment, investigations, management, and the complications in diabetic emergencies. As you can agree, that's quite a lot in the time available, but judging by the questions you ask and so forth, I think you all have very good knowledge. We're just reminding ourselves and hopefully clarifying a few things. So my presentation outline is as given. I'll give a brief introduction. I'll look at DKA, overview of DKA management, then I'll look at HHS, and finally a few lines on hypoglycemia. My name, as you was already mentioned, is Martin Nsubuga. So in regular clinical practice, there are three common diabetic emergencies. Diabetic ketoacidosis, quite common and maybe the initial presentation, particularly in type 1 diabetes mellitus, but also in type 2. Then there's hypoglycemia, which is also common and is often missed. People just say this person is acting odd until you delve into what is happening and you take good investigations, then you find the blood glucose actually dips at certain periods of the day. Then the small hyperglycemic state. And all could be rapidly fatal, and that's why they are of importance to us. Diabetic ketoacidosis have a high index of suspicion. It can actually be missed, you know. It can be, it may not be so obvious sometimes. So, but nevertheless, history and physical examination should not delay treatment. The quick assessment, such treatment, and then thereafter you can go and take a much better history. The symptoms, there are those classical ones, polyuria and polydipsia, which reflect hyperglycemia. Others, unfortunately, sometimes the patient won't tell you that because he's already in coma. And the only clue may be you find they have a big bottle of mineral water. And you say this man must have had first symptoms. And then, you know, because sometimes the people who bring them don't even know. But there are other important symptoms: vomiting, abdominal pain, shortness of breath, which indicate the likelihood of ketoacidosis. And symptoms of any precipitating condition may also be present. The earlier patient had a cough and so forth, weight loss and so on. Then an examination may find severe dehydration, may find tachycardia, may find hypotension, hyperventilation, so-called Kussmaul respiration, which the clinician ought to remember. Kussmaul respiration can be a very, very important clue in the emergency unit. There may be drowsiness or coma, and the smell of ketones on breath. Yes, ketones, some people I'm told can't smell ketones, but when you can smell them, they can be a very important clue, because we go there and the patient is breathing deeply and you smell ketones, and then you've almost clinched the diagnosis. So how do we diagnose? Basically, all must be present, but facilities may not allow you to do all the three. There's the mnemonic DKA, a blood glucose concentration of more than 11 millimoles per liter, or a patient known to have diabetes mellitus. To the K, a capillary or blood ketone concentration of 3 millimoles per liter, or significant ketonuria. I think we all agree, 2+ or more in the standard urine states, 2+ or more. I get asked that every day, and I think somebody was asking 2+ or more. And then the A, which I highlighted, not for emphasis, but to know it may not be universally available to you, but you may, if you can, you do a carbonate concentration, which should be less than 15 millimoles per liter, or a venous pH. If you can do you can determine the venous pH of less than 7.3. The Americans, like the anion gap, they do the anion gap, which more than 16, I put there 20, but I think 16 is the cutoff. Anything higher, you are likely to be handling DKA. Severe DKA, what should really worry you? The venous, is it, I'm not audible? Venous bicarbonate of less than 10 millimoles per liter, you are getting into trouble. Arterial pH of less than 7, if you have ability to do the ABGs, you're getting into trouble. Hyperventilation, you're getting into trouble. Hypotension with a BP of less than 90 millimoles, systolic blood pressure of less than 90 millimoles, millimeters of mercury, you are getting into trouble. And a depressed conscious level. You need to document the Glasgow Coma scale from the beginning. Treatment should be commenced immediately to avoid mortality. If we don't intervene, they die. So go obtain good intravenous access. If peripheral access is difficult, insert a central line. You can ask the ICU people, you can ask the anesthetists, you can ask the intensivists, you can ask emergency physicians to help you insert a central line. So you need good IV access. We have an issue there because people say IV access, they get a gauge 22 cannula and they put there. You are not going to achieve your goal. Get a good line, 17 at least, 18 cannula, and then you have good access. Commence IV saline and insulin immediately. Now there's a debate, should you put all of them in intensive care, high dependence? It depends, not all of them, they can be managed on the general ward. And that country, I think we still have issues with ICU beds. Maybe we have HDU now in most big hospitals, but you may not have ICU access. Don't be discouraged, you can still manage the patient, but you will seriously consider ICU if the patient is confused or unconscious or hypertensive, or those kind of patients when venous bicarbonate is very low or the pH is less than 7. I think they should seriously consider ICU. If ICU HD is not available, then as much intensive monitoring as is practical in the circumstances is highly recommended. I always tell the interns, you don't admit a DKA and disappear. You won't find them there. You have to keep monitoring, ask for help, adjusting, and so on until that patient is out of trouble. If you don't do that, unfortunately, you return and they tell you he or she is not on the ward anymore. Continue. Intravenous fluids are key. Variable, but by and large, give at least 1 liter of normal saline over the first hour. The rate of fluids thereafter depends, of course, on age, fitness, but typically 1 liter in the next 1 hour, 2 liters in the next 2 to 4 hours, then 1 liter 4 to 6 hourly. Reduce rate in the elderly, cardiac disease. Somebody was already asking about CCF, you go slow, and in mild DKA when bicarbonate is more than 10. More rapid infusion increases the risk of respiratory distress syndrome. Switch to 5% glucose, 1 liter 8 hourly once blood glucose is less than or equal to 14 millimoles per liter. Then you continue normal saline concomitantly. If, however, you can do concomitant normal saline and dextrose if the patient is still volume depleted. So much as you have a protocol, there's still quite a lot of reviewing and a lot of decision making to do in between as you manage the patient. There is universal agreement that the most important initial therapeutic intervention in DKA is appropriate fluid replacement followed by insulin administration. The main aims of fluid displacement are restoration of circulatory volume. So you're not just giving some fluid, you have to ensure you are restoring circulatory volume. You are clearing ketones. When you give fluids, you perfuse the kidney better, and quite a bit of the ketones are excreted. And you correct electrolyte imbalance. The case they showed us, presented with very severe hypokalemia. So that has to be addressed as you treat. Typical deficits in DKA, just to give you an idea, because sometimes you put the fluid, you go away and you return. For some reason, it has been slowed down. Or the fluid is replaced at a lower rate. I think, it does happen on the ward. So water deficit of 100 mils per kg. So if the patient is 60 kgs, you're talking about 6 liters of a fluid deficit, which you are supposed to address. Sodium, 7 to 10 millimoles per kg, chloride 3 to 5 millimoles per kg, and potassium 3 to 5 millimoles per kg. So they're largely in deficit, even when they come with, sometimes they come with a hyperkalemia, but sooner or later it will be a hypokalemia. So insulin, a fixed rate intravenous insulin infusion, usually 0.1 units per kg body weight is recommended. Yes, infusion pumps might be an issue where you may have to settle with source for substitute insulin, but you clearly know if your patient is hypotensive, you're going to have an issue. Or insulin will only be adequately absorbed when the blood pressure is sufficiently corrected. But that's a good way to start. It may be necessary to estimate the weight of the individual. Most times we do about 6 units. We are sure most people will be about there. But if it's a big guy, you may have to go higher. If a very small lady, you may have to go lower. Insulin has several effects, but the following are the most important when treating DKA: suppression of ketogenesis. Insulin is not just given to reduce glucose, but to suppress ketogenesis. And the ketogenesis is the problem you are really handling, because that is what is causing acidosis. That's what causes you the coma. That what is causing you the vomiting. So you need to suppress. Fortunately, you need only small doses to do that, to suppress the ketogenesis. Then you reduce the blood glucose, and then the correction of electrolyte disturbance. If you find the hyperkalemia there, sometimes initially hyperkalemia, which can be addressed when you give the insulin. Insulin infusion is made up of 50 units of soluble human insulin in 45.5 mils of 0.9% sodium chloride solution. This is a maybe redundant detail, but I get often asked, how exactly do we mix it? So if you can give very precise instructions, you can save yourself the problem of returning, oh, well, the pharmacist couldn't calculate it for us, we had difficulties and so forth, especially when you are on a general ward where this is not something which is done on a daily basis. So you can give stay behind to give very precise instructions such that what is done is exactly what you expect. Insulin therapy, once glucose falls less than 14, because of the risk of hypoglycemia, you have the dose of, like they did in the patient, you have the dose of insulin and then dextrose. 5 to 10%. Some say 5, some say 10%, either way. Again, depending on availability and how your pharmacy is able to support you to provide the various concentrations. Again, potassium, only 5.5. If it's 5.5 and more, you don't give. When it's normal, you already start. When it falls to below 4, like in the patient we've had, you already go for 40 millimoles, into 1 liter of fluid. Again, I get asked, were we giving potassium, doctor? It is normal. Yes, you give because it's going to drop. So you already start supplementing because the insulin is going to drive it down anyway. We continue, Dr. Jimmy. Investigations. Again, these, I think even in the other patient, manage the patient. Of course, you'll know the insulin, you know the ketonuria. Then these other ones come later when the patient is already responding. You want to make a better diagnosis. Don't send the DKA to the chest, to radiology after you had crackles. The patient will be there and the BP will be dropping. When they return, you now be in deep trouble. So investigations are not the most important thing, but they help you as a doctor to make a much clinician to make a much better assessment of the patient. Blood glucose we mentioned, urea and electrolytes. These are critical, very important. Venous bicarbonate I mentioned, ECG, particularly the older people, chest X-ray because pneumonias, chest infections are common, aspiration, canoca, all these. Urine and blood cultures, these are critical if you are supported by a good lab, because the other patient we just had a UTI, they may have a septicemia, they may have what. So these cultures help you. In the few days that follow, you'll have good blood culture results that are able to guide your antimicrobial therapy. Arterial gases, if you have access to this, but I think gradually these will become very available. The gadgets are smaller, and I think we shall advocate that they are there. After all, we are training emergency physicians. They should be able to access these and guide therapy. Arterial gases, especially if there is reduced conscious level or respiratory distress of the patient is hypotensive. Other investigations may be clinically indicated, throat swab, lumbar puncture, CT brain, all those, depending on your findings. Other measures, strict fluid balance. Urinary catheter if incontinent, or if you urinary output after 2 hours. You want to monitor the urinary output. Consider inserting as a CVP line, central venous pressure line, if the patient is elderly or has evidence of poor left ventricular function. Insert an NG tube if the consciousness level is impaired. Remembering also to protect the airway, because this is standard for the unconscious. And consider thromboprophylaxis if there is severe dehydration or the patient is elderly. Broad spectrum antibiotics should be given if there is evidence of infection. We mostly start an IV antibiotic. I think the newer guidelines agree that pretty much start an antibiotic and it will supplement your therapy. By the way, patients almost always will have a leukocytosis, which may not necessarily mean infection. That has to be remembered. Complications, of course, hypoglycemia and hypokalemia, almost invariable unless you look out for them. You give the glucose at the right time, you have the doses of insulin at the right time, you give the potassium supplementation. If that is not done, it will happen. Patient will who came with a blood sugar of 27 will surprise you when you go and the sugar is 3.7 or 3.3 or 2.2. And then you have aspiration, these are unconscious, they're comatose, they're vomiting. So showing an NG tube and airway protection in the unconscious patient. Underlying conditions, ensure these are identified and treated appropriately. The patient had a pneumonia, they can have other things, they may have a myocardial infarction, they may have a malaria, many things could go wrong. So always look for the underlying condition. Yes. These are minute. Sorry about that. I should have split the slide. Cerebral edema, don't forget, especially in young adults, teenagers. Those are the ones at greatest risk of cerebral edema as you rehydrate them. And the symptoms, as we know them, headache, bradycardia, and the rising BP. The clue to this is your patient appears to be improving, sugars are coming down, breathing better, BPs are good, waking up, and then all of a sudden, the level of consciousness starts to deteriorate. That's when you suspect possibility of cerebral edema. So, as it states, they are changing neurological status, decreased consciousness level, restlessness, irritability. Think of cerebral edema. Focal neurological signs, convulsions, papillary edema. How do you manage? You exclude, of course, hypoglycemia because of the neurological signs. Here it would be best you send them to intensive care unit. You can give mannitol to 20% at 5 ml per kg over 20 minutes. Obtain a CT scan of the head to exclude other causes, of course. Could be dealing with a meningitis, could be dealing with an encephalitis. Hypophosphatemia, this may occur in DKA and has been associated with a wide range of metabolic disturbances. Phosphate depletion persists for several days after resolution of DKA. However, studies have failed to show clinical benefit from phosphate replacement. So we will recognize it, but we're not too keen to give phosphate supplementation. Hyperosmolar hyperglycemic state. MakCHS, some literature still calls it by the old name, but I think we all agreed we change the name. This is characterized by hyperglycemia and high plasma osmolarity without significant ketonuria or acidosis. Ketones are negative, and then the bicarbonate levels are normal, pHs are normal. Clinical characteristics, type 2 diabetes, usually in patients over 60 years, they tend to be the seniors, but I've seen it in very young people also. Up to 40% of cases occur in previously undiagnosed patients, so it may be the presenting symptom. The onset is often insidious with vague symptoms, including confusion and drowsiness with features of dehydration. An old man, drowsy, weak, have been unwell, be very suspicious. It's necessary to look for a precipitating medical condition, sepsis, myocardial infarction. In this condition, the high hemodynamics test is the best indicator of severity of illness. Hypertension, tachycardia, cold peripheries, you are now dealing with a very, very, a very severe case. Dr. Jimmy. So diagnosis, hyperglycemia, blood glucose is usually very high, up to 50 millimoles per liter, with a calculated osmolarity. The figure, the figure disappeared. I think this mortality was 280. Need to check the figure. Serum bicarbonate is usually more than 15 IE, almost normal. On the urinary ketones, 2+ or less, normally 1+, or even nil on the standard dipstick. The hallmark of diagnosis, severe hyperglycemia with relative low or no ketones being seen in the urine, and the plasma bicarbonate normal or only mildly reduced. Then you calculate the plasma osmolality and it's very high. Management is as for DKA, but you need to note the insulin infusion rate should be halved. As these people, much as they have very high sugars, can be quite insulin sensitive. So instead of doing 0.01, you may do 0.05, and then have that after as the sugars drop. They are very, very insulin sensitive, so you have to be careful about that. Much as they come in when the sugars are wild. The elderly are more likely to need a central venous special line to optimize fluid replacement. If serum sodium is more than that, you may consider doing a half strength normal saline. But by and large, normal saline is okay, you'll be fine. The MakCHS, the big problem is the risk of thromboembolic disease. So you anticoagulate them fully if there's no contraindication, if they have not had recent surgery, if they have not had a recent GI bleed, you treat them as if they're already having a thromboembolic phenomenon. Most patients can eventually be managed with oral hypoglycemic agents and diet, but recovery of insulin secretion may take time, and insulin may be required for a few weeks. Yes, because the sugars are so high, they induce a little bit of glucotoxicity. So the pancreas may take a bit of time to wake up. So the patient may have to be put on insulin, which sometimes they generally hate, and we too are hesitant to give, but it may be inevitable to do that for a few weeks as the glucotoxicity is reversed. Then we go to number 3, hypoglycemia, which is common. We should be able to deal with it, but sometimes we miss it. They're not always unconscious. They may be conscious, but then they bring you know, this patient is in the line, but the blood sugar is 3. So don't take it lightly. Or one of the patients you are treated or is preparing for surgery, they say, oh, you know what? The blood sugar is 3. You, of course, ABCDE, airway, breathing, circulation, disability. We went to this exploration. They were very well mentioned in the case. We shouldn't take a lot of time because this time the patient is conscious. Then you stop the insulin stop. They take a pure fruit juice, for example, orange juice, or they may take teaspoons of sugar, 3 to 4, dissolved in water. After 10 to 15 minutes, you check again. If it's still less than 4, you repeat either the juice or the sugar solution. Then you monitor again after 30 to 45 minutes. If they are due their meal, they ask them to take their meal, have your meal, which should sort out the problem. Occasionally, these patients are on sulfonylurea, so the problem may linger on for much more than 1 hour or 2 hours. You may be in a little bit of, the patient may be at risk for much longer. Now, the other category are the unconscious ones. They may be unconscious, they may be having seizures, or may be very aggressive. Again, you go through the A, B, C, D, E, airway, breathing, circulation, disability, exploration. You stop the insulin if they're on an infusion. Then if you have IV access, you give 100 mils of 20% glucose at 400 mils per hour, of 200 mils or 200 mils of 10% glucose at 800 mils per hour. That is over 15 minutes. You repeat glucose 10 minutes later. If it's still low, you repeat the same. Once the patient recovers, they have a normal meal. If you don't have IV access, then you try, there are some gels which you can put in the mouth. They are here, but not universally available, or you can try glucagon, again, not universally available in our setting. You should be able to quickly get IV access and run in either 20% glucose or 10%. Yes, symptoms which we know very well. Again, sorry, the slide is, the writing is minute, but there are autonomic symptoms. These are the ones that alert you, and the ones we again try to teach both the patient and their caregivers. Autonomic sweating, palpitation, shaking, hunger. And this happens when they're in the line. Every so often they say, you know, this guy is sweating profusely. Of course, the team should be aware that this could be an indicator of what? Hypoglycemia. And then there are the neuroglycopenic symptoms: confusion, drowsiness, speech difficulty, coordination. And then there are the others, the general malaise, headache, nausea. It could also be pointers to hypoglycemia. The reason to know, the need for knowing this is that the problem may be recurrent for the patient, overdosage, maybe have funny habits, maybe eating late and so forth. That kind of thing, a problem may be recurrent, and you need to find a long-term solution to it. Then, of course, I think we're now close to the end. In the time allotted me, I don't know whether I'm still in my time. I don't know who keeps the time. I'm over. Like 2 or 3. Good. So then the last slide is just to the risk factors. It's not there. Oh, okay. There was a slide on risk factors which have to be, again, as clinicians, we must be aware the alcohol, the sulfonylureas, the chronic liver disease, the chronic kidney disease, you know, late meals, you know, sometimes elderly on insulin, giving drugs themselves, then they overdose, that kind of thing. Then a few other endocrine causes, hyperadrenalism, a few known risk factors. So, you know, this patient is at risk. We need to take adequate precautions for them not to go into hypoglycemia. Those are the references. I think that is it. I want to thank the SEED team, Dr. Tierra, who invited me. Please come and say something, and everybody who is here, and all the health workers listening on the electronic, listening to us over the Zoom. Thank you very much for your attention.
Yeah, thank you very much, Dr. Martin, for this wonderful presentation. I see some questions which are coming up on Zoom, and Dr. Jjunju is responding to most of them. Yeah, for the Team again, keep putting up your questions. Dr. Jjunju, go ahead and continue responding to the questions. And then some of them we shall have a session that we shall look at the end and we respond to some of the questions. I think let's move straight to Dr. Dickson, who's going to take us through the approach of a patient with a diabetic emergency.
Oh, yeah, once again, good afternoon, everyone. Yeah, my name is Dickson again, and my talk is going to be about the initial approach to diabetic emergencies, and it's basically going to be a build-up on what Dr. Nsubuga has already, labored to try and take us through. So his presentation was really great, and it tackled really a lot what mine would drill into. So I'm just going to pick out a few pointers that really speak to, that patient who presents to you in the ED and you need to stabilize them in that acute illness state and have them move to the next department where they can be, further managed. So that's going to be my outline. I'll do just the initial approach, and it's really, this really cuts across any patient that presents in an acute illness state. Then specifically, I'll talk about the initial or acute management of the three diabetic emergencies, and that's the hypoglycemia, DKA, and hyperosmolar hyperglycemic state. So, on to the next slide. So the next slide. Okay, so we'll move to the next slide, and okay, so as you can see here, and so this is like the initial way you approach any patient who presents acutely. The first thing to do is to ensure that their airways are patent, and you intervene on it if at all there's any compromise to it. And the basic maneuvers that we do are the usual ones: open the airway either with a jaw thrust or a chin lift. Then you assess their breathing, and here you're doing their saturation. If there are oxygen sats, you're auscultating bilaterally just to confirm if there's bilateral air entry in the chest and whether there are any added breath sounds. And in circulation, you're doing their blood pressure, you're doing their cup refill. And just already seen that patients who present with diabetic emergencies are almost always dehydrated. So it becomes important to, for you to assess their circulation really comprehensively, because that's the only way you're going to know if they're, dehydrated or into a state of shock. Then D is actually of paramount importance. For me, I would actually advise that if you think the patient has DKA, then if at all you're able to call them out and they're responding, you switch to a D before you actually do the breathing and assess, or you do a blood sugar level at that point, because conventionally we do the RBS under the disability stage of the ABCD assessment. But if you think it's a diabetic emergency, I would rather that you do the D before you actually even, if I told you, you've called out the patient and they're able to communicate, verbalize to you, you could skip over the B and the C, and you do the RBS at that point. Then you go on and do the E, which is exposure, looking out for any external injuries. So any skin sores that you could have, that may not be overtly visible on the patient before you expose them, and then you also take their temperature at that point. So yeah, I've been over this. So in C, we've emphasized this already. Once you get IV access, again, it has to be good IV access. Peripheral lines are good, but if you cannot get them, a central line becomes, your go-to alternative. And the initial bolus of fluid, we've been over this. It's usually 2 liters in adults, but this is like the minimum for everyone who presents in a diabetic emergency. So the upper normal that you go up, the upper requirement that you go up to is really variable depending on how the patient responds to the initial fluid bolus. So if you have the 2 liters in initially, you reassess if the patient's circulation is getting better. And if it's not, then you need to add them more boluses, as the previous speakers went over them. And so for children, and someone asked about this, we don't want to be very liberal in giving them fluids because of the risk of brain edema. So you give them the boluses, but at a slightly much slower, speed, and you aim to give that initial fluid fluid bolus in a duration of about an hour, which is quite different for adults, where you want it to run in immediately when the patient, gets to your department. Yes, next slide. So this is important, and because a good number of these patients could present with, an airway compromise of sorts, either due to a depressed GCS that they're unable to maintain it patent, or they have copious secretions, and there's a very huge risk that they're going to aspirate. So here it becomes important that you get them, get their airways secured with an intubation. So there's certain precautions that we take when we are going to intubate these patients. I guess this is one of those classic examples where we want the most senior person to intubate the patient, because so when you paralyze the patient, there's going to be that period of apnea when they're not breathing. So in these patients, that period needs to be as short as possible. For a reason, they're already acidotic because of they're having a lot of ketones in their system. So you need to have them tube very fast and blow off the CO2, which is going to worsen the acidosis. So the longer they stay apneic, because you're doing several attempts to pass the tube in, they're going to become more acidemic because the carbon dioxide is accumulating at that point. So it's one of those situations where we want the most senior person to handle the airway, have the intubation done like on the first attempt. Then as you're setting your vent settings, or if you're going to bag, if you don't have a ventilator in that case, bag them at a much faster rate than you would do for another patient, and set high tidal volumes for them. And then the choice of paralytics, there's also a certain precaution here that we need to always consider. The most abundant paralytic that we use is succinylcholine, but it has an effect of causing hyperkalemia in a way that, being that it's a deparalyzing muscle blocker, it causes release of potassium from the cells when the muscles contract. So it's those situations where you don't want to use it unless it's the only agent that you're having at the moment, or you're sure the patient's potassium levels were low or were normal at the point when you're intubating them. Yeah, so we'll move to the next slide. Yeah, so that's basically it for any patient who generally presents in a diabetic, emergency state. And so this is just, on this slide is just kind of things that we've been over. So I'll just skip over this because it just talks about the history. And then these are the clinical signs of hypoglycemia that Dr. Nsubuga has already taken us through. So I'll not go over them again. So this Cosmos breathing, yes, Dr. Nsubuga has already spoken about it. Patients labor to breathe, and they take these deep breaths to try and blow off carbon dioxide as a compensatory mechanism to sort of blow off the carbon dioxide and return the acid levels to normal in the patient. Then so like we said, HHS or HHNS is typically similar to DKA. However, in their presentation, there's a bit of differences, and there could be, the things that you're going to look at to know whether it's a DKA or or HHS. And so specifically, patients with HHS may present with a stroke-like syndrome. And it's important that for these particular patients, you're going to rule it out by doing an RBS if it's elevated and they have features that may mimic a stroke. So at that point, you might think it's a hyperglycemic a smaller hyperglycemic state as opposed to a DKA, because the symptoms, those are the only symptoms that could help you differentiate the two. Both of them will be hyperglycemic. Yes, we say that HHS will have a much higher glucose level, but it's not something that is cast on the stone, that anyone with a very high blood glucose level is HHS and not DKA. So maybe these features can be important if you want to, make a distinction between the two. So DKA may not have these stroke-like symptoms, like visual blurring, hemiplegia specifically, or loss of vision in one eye. So we'll move. Then, so this is just a categorization of these diabetic emergencies. Just, I think, bring it out that elevated glucose is just part of the pathogenic spectrum of developing the diabetic emergencies. So what happens is when you're insulin deficient, your blood glucose goes up. This elevated blood glucose is the one that causes you the two complications of DKA and HHS. So elevated blood glucose is just in between, the low insulin state and the development of the diabetic emergencies. So it's not a complication in itself. And that's why when we're treating these patients, we don't look at glucose level as a parameter to make decisions on whether to stop, increase, or reduce the insulin doses, but rather we look at it as a pathogenic change that brings about the two complications. So the investigations, we've been over them. I'll just emphasize how we interpret them. So specifically, the ones that are important in a setting that is not so robust is doing an RBS, looking at the electrolyte levels. Then if you're in a center that's a bit of advanced and you can do a blood glucose, a venous blood gas or an ABG, it's important in helping, to guide you make a decision either to continue treatment or de-escalate treatment. So the next slide is just going to show us how we interpret these slides. This is a bit of more investigations as well. And here you're looking at what triggered the diabetic emergency. In our case, I think we had infections and the source was the chest, and we did a chest X-ray for that patient. So we think what triggered the patient in the case that was shared was a pneumonia. So that's when doing a chest X-ray becomes relevant. Then in certain cases, ischemia can trigger a diabetic emergency. So that's when doing an EKG becomes relevant. And the labs, you're basically looking out for an infection or pregnancy, which oftentimes also is listed as a trigger for diabetic emergencies. So how we interpret it, so it's here. So when I believe at this point, most hospitals in Uganda can do serum electrolytes, and really it's the not extended electrolytes, sodium, potassium, chloride. So sodium can be anywhere in these patients, elevated or low, but it's most times low because of the osmotic, they have osmotic diuresis, they're passing out a lot of urine, and in that case, sodium moves out with the urine. So oftentimes their sodium levels are going to be low. But remember, we have an effect of hyperglycemia. Glucose in the system sort of dysregulates the sodium balance. They are what we call sodium glucose co-transporters on all cells. So when glucose is high, these sodium glucose co-transporters move some of the glucose into the, move glucose and potassium, and sodium into the cells. So what happens is when you take off a blood sample, the machine is going to read a lower sodium level than what the patient, correctly has because of the glucose that's sort of dysregulating the balance of sodium. It's moving some of it in the cells, but in a nutshell, it's still remaining within the patient's system. So each time you're looking at the patient's sodium level, you have to correct it for the glucose level that they have. So, and there's that very simple formula, which I think if you're interested, you can remember it any day, anytime. So it's the sodium that's the corrected sodium is equals to the sodium that's measured on the machine, that's by the electrolyte machine, plus glucose divided by 4. So like I told you, glucose, when glucose is high, it causes the sodium glucose co-transporters to be active and moves some of the sodium into the cells. So when you measure the glucose level in blood, it's going to appear a bit low, but that's not the actual sodium level. So you have to correct it for the level of glucose, meaning that patients who are very hyperglycemic, they could have much lower sodium levels that are not accurately, what they have in their entire fluid system. So I mean, that's why it becomes important to always correct it. It's a much harder formula, but I believe this is very accurate and easy to remember. And it helps you to make decisions when you're choosing the crystalloids to use to manage the patients. Because if the sodium is high, then you're going to be skeptical on using the 0.9 sodium chloride. So you probably use the half strength sodium, or you move on to you use maybe Ringer's lactate in that case. All right, so next one. So for potassium, like we said, potassium moves with insulin. So when you administer insulin, some of the potassium shifts back into the cells. So the readings that you get in between there once you started the patient on insulin may also not be so accurate. That's why we emphasize it that before you start insulin, you must be sure that the patient's potassium is within the normal ranges and not low. So we're going to look at what ranges are safe to give the patients insulin. So then this is also another way, we look at interpreting labs for patients with DKA. And so we've been over this, but I guess the formula has never shared this. These patients are always going to have a metabolic acidosis. In this case, it's going to be an anion gap metabolic acidosis. So this very quick, simple formula for calculating the anion gap. And I think in most of the centers in Uganda, we may not be in position to calculate it because the electrolyte machines don't give us the bicarbonate level. But if you're able to do an ABG, then you could calculate it. So this is just a simple formula. Anyone that's interested can also remember this anytime, any day. So it's sodium minus glucose, minus chloride plus bicarb. So what you're doing here is you're getting the most abundant cations in the system and subtracting the most abundant anions. And the figure you get is the anion gap. So the normal one is less than 12. So anything above that, we describe it as an elevated anion gap. In DKA specifically, or it goes above 15. So that's why you're seeing the figure there being AG or anion gap being above 15. But the normal one is anything below 12. So which means that 12 and above is considered to be elevated. But for DKA, because we said the ore is in a hyperosmolar state, the anion gap always goes above 15. So management, these are just the goals. We've been over them, but maybe what I want to emphasize is that, as you can see, there's no, in the acute management of DKA, there's no administration of insulin as a goal. I don't want us to confuse this. So here, what I mean is, when the patient first walks to you in that first 1, 2, or 30 minutes, I'm going to rush to give them glucose because whatever is going to kill them is not because they're having an elevated blood glucose level, but it's rather the complications that the elevated blood glucose levels is causing. That's why we want to emphasize that in that first 1 minute, 30 minutes or 1 hour, the goal is to, correct the electrolytes and the fluid, the intravascular volume collapse. So IV fluids become the most important, treatment in the acute illness state for patients with diabetic emergencies, and also correction of their electrolyte derangements. If you're sure that you have a good balance of their electrolytes, and more specifically potassium, as we've seen, then you can go on and start your insulin infusions. Yeah, so this just emphasizes what I've just spoken about, fluids and electrolytes. Once you're sure electrolytes are in good ranges, and the electrolytes here, we're specifically talking about potassium. If potassium is not low, then go ahead and administer insulin, start your insulin boluses. And the reason is what we emphasized already. When patients are in DKA, they're losing a lot of fluid, renally, and electrolytes also move with fluid. So they're most likely always going to be in a state of hypokalemia when they present. And if you start your insulin early before you've corrected the hypokalemia, you're going to worsen it. The effects of very low hypocalcemia is, cardiac arrhythmias. So I guess it's one of those situations where a patient with DKA comes in, you're thinking you're doing everything right, but you're not able to monitor them effectively. So you start your fluids, you start your insulin, and the patient seems to be getting better. Their mentation is going up, and they just as you think you're getting them back, they get into a cardiac arrest. So it's most likely that you worsen their hypokalemia, and they got a bad cardiac dysrhythmia. So it's important that even when you don't have the ability to do a potassium level, just go ahead and correct the potassium. At the time when you're starting the insulin, start the potassium as well. All right, so we'll move on to the next slide. Yeah, so this is just the order of how we want things to be running when you're managing a DKA patient. Fluids first, look at potassium, then insulin comes in third. So I've tried to explain this. After calculating their corrected sodium, you need to make a decision whether you're going to use the 0.9 sodium, whether you're going to use the 0.9 normal saline, or you're going to use the half strength of it. So if they're hypernatremic, it's advised that you use the 0.45, which is half the usual normal saline that we have. I don't know, this is not very readily available in most settings, but I think the option can be using Ringer's lactate in this case. If the sodium is high and you don't want to make it worse by giving them a 0.9 sodium chloride fluids, then you just choose Ringer's as an option. But this is dependent on the value that you calculated using the formula for correction of sodium level, where you're using the corrected, the sodium that's measured by the machine plus glucose over 4. So this is just a schematic representation of when do we make decisions to administer insulin to these patients. So if potassium is less than 0.03, hold the insulin at this point, correct the hypokalemia, and once it's between 3.5 to 5.3, you can start the insulin at that point. And if I told your first measurement is in between 3.3 to 5.3, then give them they replace the potassium and as well start the insulin at that point. So the reason you're giving them potassium at this point is because it's going to go down once you start your insulin boluses. So it's important that, yes, you first measure it before you make the decision to start running the insulin. And if it's above 5, then above 5.3, then you don't replace it, but rather just start insulin. If it's above 6 and there are electrocardiographic changes, you need to actively treat it as a hyperkalemia by initially giving them cardiac cell stabilizers like calcium chloride or gluconate, and then also doing active management to try and lower it down using things like salbutamol or sodium bicarbonate. So that's the same thing. It's just a re-emphasis of what I've just, but here we're just, looking at the doses of insulin, which I believe we've already gone through. So if it's an adult, you want to start with 0.1 units per kg, and then you're going to repeat it every 1 hour based on the glucose levels. So when do we stop insulin? This was spoken about. I just emphasize it here. If we don't use glucose to make a decision to stop insulin, simply because, like I spoken about it before, the glucose is just, the elevated glucose is just, a pathogenic process that's going to cause the complications. So we don't use it as a target to, stopping insulin infusion in patients. Rather, we look at these 3 points that I just wrote down in the last box, which is the anion gap, less than 12, so which means it has gone back to normal. So at that point, so anyway, the criteria is any presence of any two of these is just good enough to make a decision and stop the insulin infusion, but rather continue with the subcutaneous one. So if at all these parameters fall back in range, the 3, as you're seeing them down, then you can stop the insulin infusions and you rather maintain the patient on subcutaneous insulin. So the other parameter was, if you could just go back, was the pH of 7.3, and then the bicarb level, which is set above 15, 18. So it means that the acidosis is corrected at that point. But there's always a challenge on, how you're going to get these results if you cannot do an ABG. I guess this is where your clinical judgment becomes important. So once you hit a normal glucose level of less than 14 or about 14, then you stop the insulin infusions and then fix the patient on boluses, on subcutaneous, injections. So yeah, there's been very many, I think, questions about a glycemic decay in the chat. So this typically happens when a patient is in DKA, but their blood glucose levels are within normal ranges. So what happens is this could be a patient who came in shortly after getting their injection dose of insulin. So it means they can be acidotic at that point, but the glucose levels can be normal because they just received an insulin dose before they came in. Then the other triggers are starvation. So if someone has not been feeding, it doesn't mean that they're not going to be insulin deficient. They can be insulin deficient, but their blood glucose levels are going to be low because they have no, glucose, they're not feeding for a while. So those patients could have glucose, they could be insulin deficient, but they can still metabolize their fatty acids to make the ketones. That's typically what causes DKA. So their blood glucose levels are going to be normal. Then patients who are on sodium glucose reuptake, transporter 2 inhibitors, there's quite a number of these. I don't think we commonly use them, but these patients can present with a normal overall glycemic decay simply because the drugs are preventing reabsorption of glucose from either the GIT or the renal system. So their blood glucose levels can be normal, but they can still metabolize the fatty acids because they're insulin deficient. So what are the takeaways from my talk? One, the goal of treatment in DKA is not a normal blood glucose. Then the common confusion that we should always treat these patients until their blood glucose levels normalize would almost always causes us complications, or sometimes it makes us to discontinue treatment when the patients are still in DKA. So we aim for correction of the acidosis and not a normal blood glucose level. And insulin is great for correcting ketoacidosis and not hyperglycemia. So yes, the blood glucose levels will go down, but like I said, it's not our target, but rather correction of the ketoacidosis. And we need to administer insulin up to a point where the anion gap goes back to the normal range. That means that we've corrected the acidosis, which is our primary problem in DKA. I think after this point, I had just a couple of 2, 3, 4 slides about hypoglycemia, but I think a lot has been spoken about this, so I may not have to go through it again. So I'd like to end my presentation at this point, and thank you all for listening. And I think we're going into the next session, which is probably as the moderator is going to tell us. So thank you.
Yeah, thank you very much, Dr. Dickson. It was very wonderful and elaborate and good. Dr. Jjunju is responding to your questions. And I think our next session is about the nursing care for a patient with a diabetic emergency that is going to be done by Sister Benda.
Thank you very much, moderator. My name is Benda. I'm going to take you through the nursing care in diabetic ketoacidosis. I think the slide. You're giving me what? Slides? Slides? Okay, objectives were knowing what diabetes emergency is, nursing management in diabetic emergencies, education and prevention. As nurses, we are aiming at preventing or whatever is happening, but the treatment also, we do treat, but in most cases we work under the supervision of the doctors who always let us know what to do. Another thing is, I was calling diabetic emergency, like it is when the symptoms related to diabetes is overwhelmed in the body. It might be low, or it might be high, hyperglycemia or hypoglycemia. But at this point, a patient needs hospitalization for quick attention and management. Types of diabetes emergencies and other related emergencies are: one, we have diabetic ketoacidosis, hyperglycemia, or small non-ketotic state. I call it like that. I think I use the older words, but it is HHS. It is the same. And the third one is hypoglycemia. There, whatever has been explained. Okay. Then our nursing management, like nurses, we start by assessing. I'm not saying them that on the one. As nurses, when the patient comes in, it is our role to assess the patient. As we're assessing, we really listen to our patients, what they are complaining of. They may tell you what they have taken lastly as their meals. You have to find out whether they have taken their insulin, if they have any infection, like if they are on medication. That one helps us to know what we are dealing with. Then as they're doing that, as we monitor their vitals, like blood pressure, temperature, heart rate, to see the baseline, where are we, if the patient is really doing well or not. Then we check for blood glucose. Always we find it when it is high. When we're looking for infections in those patients, the patient may complain of chest problem, or you can even listen to the lungs to see whether it has infection in the what? In the lungs or in the chest. And then these patients always smell the fruit acetone breath, which is called Kushmo, or with other smell, with the Kushmo respirations. Then they always complain of polyuries, the polyphagia, polydipsia, and polyuria. They have dry skin, they are dehydrated, sometimes they have altered mental state. High glucose, then ketones in urine. This one, ketones in urine is seen in DKA. But when we go in HHS, sometimes ketones are not there. Mostly they are not there. And their blood sugars are severely high, which cannot be seen in DKAs. I'll go back ahead. I'm following. Then, as nurses, we always ask ourselves, but why? Why is it? Why? So we are looking for what is the diagnosis in nursing. And we find out that the patient maybe is taking imbalanced nutrition that causes DKA compared to the insulin is taking. So like they eat less, they eat much, and they give themselves less insulin. So in that way, their sugars remain high, and then they end up going into DKA. Then we also, in the patient, we see fluid volume depletion, that is dehydration. Then electrolyte imbalances. Then we always ask ourselves, why is so-and-so having all this? So we just know, maybe has not known the problem the patient has got. Then we see the risk of hypoglycemia related to insulin. That is when the patient is in hypoglycemia. I'm sorry, I'm presenting diabetic ketoacidosis, but I wanted to put them in one slide, like to manage all the cases on one table. That's why I'm sorry if it is mixing you, but I think we are getting risk of hypoglycemia related to insulin administration. Then another one is risk of infection due to elevated glucose level that compromises immune function. Then maybe kidney injury due to dehydration also. So what are our goals? What should we do for these patients? Since has come to you, you have seen the patient is in that state. As the doctor said, this patient was emaciated, hydrated, what? So we always have to see what should we do for this patient. You plan ahead for your patient to manage the patient. So we are going to maintain the blood glucose within the target range. He said putting the sugar low doesn't mean that you're managing diabetic ketoacidosis, but there's a target that we really want so that the patient stabilizes. You ensure adequate hydration and electrolytes by replacing back the fluids that has lost during the polyuries that we saw, and also to balance the electrolyte, also to reduce on ketones, as it is a major problem in this patient. Then stabilizes the patient hemodynamically. This one helps us to know whether we are in the right track. So what do? We have to give fluids and close monitoring of the patient's vitals to see whether the patient is improving or not. So then we give insulin administration. Insulin administration could be infusion, or it will depend on the doctor's. It is low. Okay, insulin administration could be infusion, or depending on the doctor's order. We plan or we try to prevent complication like seizures, cardiac arrhythmias, and brain edema. I'm sorry, that's a typing error, but it was cerebral edema. Like when we are giving fluids, we really try to prevent, we are trying to prevent diabetic ketoacidosis, but there are other complications that follows that may arise in that patient during trying to manage the present complaint. Then patient's education on DM management. Of course, present education is to letting the patient know what the problem he has, how to handle it, signs of hypoglycemia or hyperglycemia. A patient is helped to know when he's supposed to go to the hospital, at what stage after seeing what. So all those things are under our nursing care so that the patient knows what to do or to deal with the problem. We work as a team, so the endocrinologist or intensivist is informed on the protocols of managing some cases like hypo or hyper. Slide the other side. Then implementation. Implementation, we are going to keep on checking. Where was that? Okay, implementation. Here we insert large bore cannula for resuscitation. That's going to help us replace the fluid the patient has lost. And also try to correct the glucose that is high. Then we administer fluids depending on the doctor's order. We administer fluids according to the doctor's order, what he is targeting that the patient should have. Then the doctor is going to tell us to give electrolytes like potassium, salts, those are salts, potassium chloride and sodium chlorides, of course, to correct the electrolyte balances as to the main problem in this patient. We have to go for the renal function test results to see what we have in our chemistry. Then fluid balance chart, it is our work. We need to chart whatever the fluids that we are putting on, not over rehydrate or to under rehydrate, to see if you're in the right track. So balance chart, fluid balance chart is very important in this patient. Then we encourage healthy diet. Healthy diet, I'm supposed to draw a plate for this patient. Like if this is the patient after discharge, our patient was discharged in the first case. So as they're going out, you're supposed to tell them what to eat, amount, timing, and the amount, timing, and what to eat. So that one is very important to them. Sometimes they underfeed themselves because they fear of raising their sugars. So we find that they are eating less than what is required by their body. So they end up having those complications like DKA or hyperglycemia or hypoglycemia. Then we always run for urine and blood culture to find out the cause of that accelerated their condition. In urine, you may find the fast cells. In urine, you're going to see ketones. So those are the things that we really look at. Then in blood culture to find out the sensitivity. Because in the first history, we asked the patient if he's on medication. So if he was on medication, why is it that he's still going up? So you need to do culture and sensitivity to find out the real antibiotic or a real drug that we can give this patient to come out of the problem. Otherwise, even if we give insulin the whole bottle at once, the DK will not resolve if we will not treat the infection. We encourage, administration of oxygen. We saw a patient had a pulmonary infection, pulmonary problem like chest infection. So, and also was desaturating. So oxygen is administered to this patient. Then monitor the patient closely for any change in symptoms and vitals continuously. More frequently, glucose and salts, because they may go into hypos, like hypoglycemia. It's more common, like we keep on giving insulin. If you're not checking, you may go out of order, like you put the patients into hypoglycemia. Yeah, mine. Okay, reevaluate fluid and electrolyte balance for adjustment if need be. Personal education on how to manage diabetes, recognize and respond to emergencies when seek medical attention. So all this is done to the patient to educate, to know their problem, how the problem is, how it's being handled. This is supposed to be for medication at what stage, after seeing what. So we are supposed to teach them the signs and symptoms that they can go if they see infections, if they see any skin problem, like any infection on them, they should run to the hospital before the problem goes out of hand. Next slide, yes. My slide is going their side. Okay, evaluation. Evaluation, we keep checking the glucose level, whether it is stabilized within target range. You assess the resolution of symptoms like dehydration, altered mental status, abdominal vital signs. So if you find everything is okay, you continue with your management. If it's okay, you need to go back where you started from to see what has not been done. As I say, we keep on having the question, why this one, why this one? It is our question in our management, why do I have this one? Why is this one? Why is this one? Where have I gone wrong? What haven't I done? So all those are the questions that we keep asking ourselves. What haven't I done? Why the person's not responding? Ensure that the patient and the family understands how to manage diabetes and respond to emergencies. Yeah, that one's education. Then modify the care based on patient's response to treatment. This one, modifying, is when you're going to teach the patient, okay, diabetes management, when to go to the hospital, how insulin is given, who to help the patient. So those are the things. You sit down with the patient and the family so that you see how you can help the patient not to go back where the patient came in with. Frequent monitoring assesses response to treatment, adjustment instrument therapy, fluid management, electrolyte management, bicarbonate therapy, and to avoid complications. All those things are under modification. So that's what you're looking at. How can we help this patient to help him or herself through that so that he can be okay and to avoid complications. Management such as hypoglycemia, hypokalemia, cerebral edema. Okay, evaluate treatment goals. Evaluate treatment goals, document, evaluate treatment goals. So we've been treating, so have we achieved what we have been doing? So you're evaluating if the patient is responding. Then document changes, yes. If the patient has not responded and you are able to change any medication, we are supposed to change, you're supposed to change as we are notifying, and also by documenting. You document, like when you started with the insulin, a certain dose of insulin, a certain amount of fluids, the formulation of insulin that you are giving, then at what stage have you reached? So everything has to be documented. Collaborate with health team. As I said, we don't work alone. We work together with the doctors and the health teams. So there are protocols, and it's not us to make protocols. It is a team of emergency people, a team of physicians say, okay, hypoglycemia in DK is supposed to be treated like this. Hyperglycemia in DK is supposed to be treated like this. So we have to alert them at that point so that they can help us in this emergency or in this situation. How have we done it? Rationale. We correct dehydration, reduce hyperkalemia by what? Hyperglycemia by giving insulin. We reverse the acidosis by giving the electrolytes. Prevention of complications by doing, like, managing a patient at the right time. Then improve insulin sensitivity, like if the patient hasn't been eating, is having infection, so we treat all the accelerating cause of the problem. Restore electrolyte imbalance. When you replace them, of course, expect good outcome. Then support organ function, that is by giving oxygen. Giving oxygen support the brain and the lungs so that the organs are well perfused. Relieve symptoms. So when you give treatment, the patient who came vomiting, abdominal pain, and urinating a lot. So by giving treatment, all those things have to go down. Educate the patient or how to manage their condition, and then reduce morbidity and mortality. So that was our main aim. So next, go ahead. Okay, it is hyperglycemia, hyperglycemia, hyperosmolar, non-ketotic, that is home. That one, almost everything was almost the same, except that I mentioned that in the hyperglycemia, hyperosmolar state, we have severe glucose, severe hyperglycemia, and we don't have ketones in urine. And also mostly they have infections like diabetic feet. So that's how we are seeing mostly, and the age of the patient also matters. It is also seen in type 2 diabetes. Otherwise, the rationale of managing it is almost the same, and the complications are almost the same. So go to hypoglycemia. I'm not seeing, sorry. Most of the things have been said. We are managing patients, educate, it is also done. Supportive management, like nurses. What do we support? Prevent falls. You have to be with the patient. You maintain airway, which was said, maintain airway, educate the family and this family. Yes, about the diabetes. Okay, information of the emergency setting for protocol, it's okay. I think everything this side has been said. I think we are okay to go. Like, okay, nutrition, we are supposed to give high carbohydrate, fast-acting carbohydrates in hypoglycemia if the patient is conscious. If unconscious, then cause for IV treatment. Next slide. By implementing these strategies over an individual with diabetes may reduce the risk of diabetic emergencies and improve outcome. Next slide. Thank you for listening.
Yeah, thank you, Sister Benda, for that wonderful elaborate presentations. I think we have come to the end of the presentations. We are going to have a short session where we shall listen to 1 or 2 questions as the team online is looking at the post-test quiz. One of the questions that I picked up online, I think the team talked about the choice of normal saline and Ringer's lactate. How do we go about the two, given that there's that risk of creating acidosis by normal saline? And then, yeah, I think these two might not be so related, but someone talked about DKA in children. I think it may not be different. Yeah, maybe Dr. Nsubuga can answer that question, and then we pick one question from the group. DKA in children, I like to leave it to pediatrician, but this protocol should help you up to a 16-year-old, but younger than that, I think you'll have to hold a session and invite the pediatricians to come and address DKA in children. I had to simply extrapolate and say, no. But 16-year-olds, it's happening. Below that, I want to leave that to the children. The question of fluid, I think, was addressed. By and large, normal saline. I think all the guidelines, normal saline. When the sugar falls, go to dextrose. You may give the 2 if you still have issues of hypoglycemia. Then there was the HHS, extreme hypernatremia. When you are not extreme, but when you are getting hypernatremia, you may consider half strength normal saline, or that's when Ringer's lactate comes in. The debate was always between colloids and crystalloids, but most people are saying crystalloids are good enough. So I think it was addressed, unless he has another issue, but it was addressed.
Yeah, thank you, Dr. Nsubuga, for the responses. One question from the group online. Go ahead. No, I think
Is muted or what? Sorry.
no, it's Issa, you can go ahead with your question.
May I? Is that me or someone else?
Yes.
Hello, this is Hisa.
Yes, Hisa, go ahead.
Yeah, my question is, in most cases in our ETU, we receive patients presenting with either DKA, but they also have hypertension. Now the challenge comes in giving IV fluids. Think of giving saline either 0.9%, but you deep inside your mind, you're like, maybe I may raise the BP. So now the challenge is the fluids titration in DKA with hypertension. That's my challenge. And I would love Dr. Martin and Dr. Nan to elaborate more on that. Thank you.
Thank you very much. DKA with hypertension. This patient is very likely, by the way, to be hypertensive. If he or she has DKA, they are likely, they will not maintain those very high BPs, given what we have gone through. The fluids are off. If you when you have a heart condition, you have issues with the heart, we talked about that. You might, if you have facilities, you have to do central venous pressure measurement, but don't be too much worried that this hypertensive will be a problem. It still will be fluid deficient, and you have to give them fluids and bring them up, correct the DKA. Of course, you have to be very, very, very careful in this situation, because if they have been hypertensive for a long time, they have probably an enlarged heart, and so they are at risk of being tipped into CCF. So you have to be cautious. That's why I said the protocol is there. Don't just apply it like a recipe, for a meal. You have to keep judging, monitor your patient, listen to the lungs, look at the JVP. You may slow down a bit the fluids, unlike in a patient who is much younger and normal. But when they are hypertensive, they are indefinite DKA, they will come in with when their BPs are down. Only when I think they improve, they'll get out of hypertension, the BPs goes up, then that's where you'll have to start addressing hypertension per se. That's my response.
Yeah, thank you very much, Dr. Martin. I think we have come to the end of our session today. We discussed quite a lot about diabetic emergencies. We have looked at overview, assessment, investigations and management and complications. We have looked at approach to a patient with a diabetic emergency. and the nursing care of a diabetic patient. At least we have acquired some new knowledge on quite a number of things, which will help us in our day-to-day practice. Yeah, I want to thank everyone who has spared time to listen to this session. You are very, we thank you very much. And then I also want to thank the panelists. You took off some time to prepare these good presentations, which were good and informative to the team. Then for SID Global and Ministry of Health for organizing this session. Yeah, I can see the poll went very well. I see yeah, you guys are answering very well. Yeah, so I think yeah, we can have 1 or 2 parting shots from each of the experts, and then we call it a day.
My parting shot, again, teamwork, extremely important. The nurses support us a lot. The laboratory supports us a lot. The cadre of doctors, the young doctors, the SHOs, the physicians. So don't hesitate to ask for assistance at that level. You may ask, call the lab for extra support. You may involve the pharmacist to do for you that fluid which you want. You say, I have a DKA, do you have normal saline in stock? So you don't take things for granted. It's a teamwork, extremely critical, and you monitor the patient. Don't write a very elaborate management plan and disappear. You have to keep coming back. Unless, of course, you have somebody fairly good to stand in for you. Thank you very much.
Yeah, once again, I was very honored to be part of this team. And maybe just as a thing or two that I like all the participants to go away with from this talk. So your partly relates to an experience that I had managing a DKA when I was very early in my career. And I'm not saying that I'm old in my career, but I mean, those days when I was just, passing out as an intern. So it used to get over my head that, glucose levels are high, but they're telling us don't look at glucose as, as an endpoint for treating these patients. So one time I had this patient, I was managing, glucose levels go to 13, patient was getting better. I really felt like I needed to get them within the normal ranges. So I gave them another bolus of insulin. They went to 7. And the patient's outcomes didn't turn out well after that. But so reading again about DKA, I realized that it was a mistake I made simply because, I didn't take so much time to understand the pathophysiology of how everything happens. So the point that we shouldn't treat glucose, but rather, glucose level, but rather the patient that we have in front of us, and making sure that it's their electrolytes, their electrolytes are within the normal ranges, is to me a very big take home to everyone who has attended this session. So if you're in a center where you're unable to do electrolytes, I'm not saying you shouldn't be managing these patients because, this is one of the commonest emergencies we manage, but just always have it at the back of your mind that their electrolytes are deranged, even if you're not sure what it is at that point, especially for potassium. Once you start the insulin infusions, go ahead and start correcting it as well, because it almost always going to be low. And again, the formulas that I shared, I think are important every time you're looking at a diabetic emergency patient for helping you to make a decision when to stop the insulin infusions or half the doses to what you started with. So I guess that's it. If anyone really needs to remember what this talk was about, it should be that you don't treat glucose levels in these patients, but rather manage the patient holistically and always remember that their electrolytes are deranged. Thank you.
Thank you very much. It has been a great pleasure having you all on this platform. And my take-home message is, for any patient with diabetes you find unconscious and you can't access the glucometer, first show hypoglycemia, give glucose. Glucose kills faster than hypoglycemia kills faster than hyperglycemia. So give glucose, then sort out the rest. Then another thing for hypoglycemia still, for any patient with hypoglycemia, kindly check out and see if the problem is the kidney or the liver. Many patients I find on my ward with hypoglycemia, they end up having chronic kidney disease. Then as the previous presenter have said, let us stop chasing glucose when managing the patients with diabetes, especially in emergencies only, but let us look for complications, but because it is the complication that are more likely to kill the patient than the glucose you are seeing. Thank you very much for listening.
Thank you very much. My take home is, as nurses, we should know that diabetes is not painful. People take it as a painless disease. Indeed it is. That's why we don't mind, or patients that don't mind about taking care of themselves. They only realize that they are in danger after getting complications. So my take home is, it is our work, people who know what diabetes is, to transfer the information to others so that people get to know what diabetes is. Many people don't know what diabetes is. It's something that can kill you while you're walking. Thank you.
Yeah, thank you, Sister Benda. The team online would like to have a look at your faces. If you can put on your videos for those who can. Yes, you can share your video and then we have a look at you.
Thank you.
Yeah, thank you very much. Yeah, we can.
Welcome.
Yeah.
All right.
Thank you for the presentation. It was really good and nice. I've learned a lot.
Thank you. Use the quiet place, you can go.